everyone, and welcome to our special webinar in commemoration of World Tuberculosis Day 2025. My name is Devi Sundar. I'm the founder of Therapist, and I'm honored to be your host today. This webinar is a part of our ongoing commitment at Therapist to raise awareness about lung health, particularly the long-term consequences of treated tuberculosis and its connection to chronic obstructive pulmonary disease, COPD. Today, I'll be exploring an often overlooked reality, how even a successfully treated tuberculosis can leave a lasting damage to the lungs, increasing the risk of chronic respiratory disease. Before I could begin, I would like to express my gratitude to each one of you joining us today in this webinar. And your presence here demonstrates your commitment for understanding and improving the lung health. Whether you're a healthcare professional, a patient, or an advocate, your role in this conversation is invaluable. Now, before I could dive into today's topic, I would like to understand your understanding and knowledge about tuberculosis. So get ready with a pen and paper to answer those three simple questions, and then I can go into my topic in depth. Now, let's test your knowledge on tuberculosis. Ready? Question number one. Which of the following is the most common symptom of both TB, that's tuberculosis, and COPD? Fatigue, chronic cough, fever, weight loss. So choose your option, which you think is the most common symptom of both tuberculosis and COPD. You have 30 seconds. Now, the next question. Tuberculosis can only affect the lungs. True or false? 15 seconds for this. Now, the third question. What percentage of TB survivors are at risk of developing chronic respiratory condition? Your options are there: 10%, 21%, 30%, 30 to 50%. And your time for 30 seconds. Now, time is up. And I'm going to reveal the answers at the end. Keep your answers to yourself. Possibly you'll be getting while I'm actually running through this webinar slides and explaining to you each slide. So you might be getting the answer and you can check the answer and I'll be revealing the answer at the end of the session. So a little intro about me. As I introduce myself, I'm Devi Sundar, founder of Therapist, where I offer a specialized integrated complementary medicine for holistic lung health, mental well-being, and occupational health. My professional qualifications are in respiratory physio, integrative psychotherapy, neuroscience, coaching, and hypnotherapy. I combine these practices to provide you with a personalized, holistic approach, and more so with evidence-based. So my approach is all integrative medicine. So where it combines all of those mind-body practices, nutrition, and movement therapies, and the complementary and alternative medicine. So I specialize in that part of alternative medicine, Ayurveda. The only reason I do this because I value human beings and I would like to provide some value to the community. And I don't want to treat the symptoms, being with multiple roles, most part of my life with respiratory physio and psychotherapist, and recently being coach in neuroscience and hypnotherapy. I feel like I need to provide more valuable resources and healing practices to people rather than just treating the symptoms. So people should feel that they can empower themselves. human beings, we all have the ability to heal ourselves. So most of the disease, which is overdiagnosed and also underdiagnosed, we can manage. So that's all my mission here is to help humanity to heal themselves as a whole, rather than just a shallow way of treating the symptoms. So I combine the modern medicine with the holistic practices. To know more about me, you can visit my portfolio, which is www.devisundar.org. So you can understand my professional credentials, my experience, and my few publications and my teaching practices. So you can have an overview of who I am. Now, today's focus is first we'll explore the link between the treated tuberculosis and the chronic obstructive pulmonary disease. While TB treatment may be successfully clearing the infection, the structural and functional damage leaves behind an increased risk for developing COPD. Next, I'll be discussing about TB can mask COPD symptoms, making it challenging to diagnose respiratory impairment. So the challenges faced by the TB survivors. Many TB survivors experience lingering cough, breathlessness, and fatigue, which may be mistaken for post-TB recovery rather than the early signs of COPD. And some key aspects I'll be also covering here, it would be the overlapping symptoms, how both the COPD and TB overlaps, and which might lead to a misdiagnosis as a common challenge, and the post-TB lung damage, the structural lung changes, which is happening inside your lung, and the long-term respiratory challenges what the TB survivors face, especially the breathlessness, exercise intolerance, and frequent exacerbation, which impacts highly their quality of life. And I also be talking about the evidence-based management strategies for post-TB COPD. The early detection and diagnosis, integrative health practices, how you can apply it in your daily life. And by the end of the session, I hope to provide you with the valuable insights and practical strategies to improve the care for individuals with post-TB COPD. So let's move on. So why this matters? World Tuberculosis Day is a powerful reminder of the ongoing fight against tuberculosis. While advancements in treatment have saved millions of lives, we must not overlook the long-term health consequences for TB survivors. One of the most significant and underdiagnosed challenges is post-tuberculosis COPD, a chronic respiratory condition that can severely impact the quality of life. Many TB survivors continue to experience breathlessness, recurrent infection, and reduced lung function. Yet this condition is often overlooked in routine healthcare. By increasing awareness, improving early diagnosis, and integrating both conventional and holistic health strategies, we can ensure that TB survivors can receive a comprehensive care they deserve. Now, let's look into the World Health Organization role in the global TB control efforts. Despite the significant progress, TB remains a major public health challenge. And I put on some statistics on the slide. 10 million, those are from the 2022. 10 million people develop active TB each year, meaning millions of lives are at risk. 1.6 million TB reported deaths occur annually, making TB the 10th leading cause of death worldwide. And to combat this, the WHO has launched the NTB strategy, which aims to reduce TB deaths by 90% by 2035 and to reduce TB incidence by 80% by 2035. And also to ensure no family is burdened with a catastrophic healthcare cost due to TB. So achieving these goals require global cooperation, sustained investment, and also innovative approaches to diagnosis, treatment, and prevention. So the WHO strategy focuses on four critical areas. The first one is early diagnosis. So expanding the access to rapid and accurate diagnostic tools for early TB detection, including the drug-resistant TB. And then the universal access to care, ensuring timely and effective treatment for all, especially those with multi-drug resistant TB. And the third one is to prevent TB transmission, emphasizing the preventive care, BCG vaccination, and targeted screening for high-risk groups. And then strengthening the health system, building a robust healthcare infrastructure, and training healthcare workers to improve TB management worldwide. So, what are the current challenges in TB management? Despite the progress, significant challenges remain in the global fight against TB. Some of the most pressing issues include drug resistance TB. Over 400,000 new cases of multi-drug resistant TB are reported annually. And treating this multi-drug resistant TB is complex, requiring a longer, more toxic, and expensive treatment with lower success rates. And the second pressing issue, is the global disparity. Access to TB care is not equal worldwide. Low income regions face limited access to diagnostic treatment and preventive care, leading to a higher TB burdens. So, addressing these challenges require targeted interventions, increased funding, and also stronger global collaboration. Now, let's look at some insights from Professor Ajit Lavani, a leading expert on tuberculosis, and he's also chair of chronic disease in Imperial College London. I had happened to present my poster recently in the Respiratory Infection Forum in Glasgow in February, and I had an opportunity, a great opportunity, I would say, to listen to his talk. And its research and analysis provide valuable updates on the state of TB in UK and the challenges we continue to face. He actually opened up with how England is burdened with TB, although we actually, one side of population or the healthcare profession say that we are reducing TB and it is eradicated, and there are a lot of miscommunication. But the truth is, in 2023, as you can see, there are 92% of TB cases in England, and mainly in the urban areas, with an 11% rise in cases compared to 2022. And this rise highlights that TB is far from being eliminated and remains a significant public health issue, particularly in the urban and migrant communities. And also the NHSA and the UKHS HSA's 5-year TB screening strategies between 2011 to 2025 focus on the latent TB detection. However, despite these efforts, screening remains inconsistent, particularly in high-income countries like UK. Many individuals, especially in migrant population, are either not being screened at all or are being diagnosed too late when they are already developed active TB. So, to address these challenges, the professor had made some recommendations in his presentation. The first one is the GP-led TB screening. One of his key suggestions is that general practitioners should play a greater role in identifying and screening high-risk individuals, particularly those from the countries where TB is endemic. A proactive approach at the primary care level could lead to early detection and treatment of latent TB, ultimately reducing the active TB cases. And secondly, review of the GP confidentiality policies for migrants. Many people, particularly those with uncertain immigration status, avoid screening due to fears related to confidentiality and legal implications. So if we don't address this issue, we miss the cases and allow the TB to spread undetected. And also, the future direction is to increase awareness and education, ensuring that the at-risk communities understand the importance of TB screening and feel safer assessing the healthcare services, and better surveillance and monitoring to strengthen data collection and follow-ups to track TB trends and screening effectiveness. And also stronger public health policies, advocating for public health changes that protect the patient's rights while improving screening and treatment accessibility. So these insights remind us that even in high-income countries, TB remains a public health challenge, and the challenge is to bridge the gap in the screening and also ensure every high-risk individual is diagnosed and treated before TB progresses to an advanced stage or causes any long-term lung damage like COPD. Now, let's explore the science behind how tuberculosis leads to a long-term lung complications, particularly the chronic obstructive pulmonary disease. Understanding the pathogenesis of TB and its connection to COPD helps to recognize why TB survivors are at a higher risk of developing persistent lung disease. So, how TB affects your lung? TB is caused by inhalation of Mycobacterium tuberculosis, which then triggers the immune response in the lungs, and this leads to an accumulation of immune cells, including the macrophages and neutrophil lymphocytes at the site of infection. And as a result, it forms a tuberculosis granuloma. Yeah, and which the cluster of immune cells attempting to contain the bacteria. And while the granuloma helps in containing the bacteria, over time they disintegrate and that is leaked due to action of matrix metalloproteinases and other proteases. This breakdown facilitates the spread of the tuberculosis in the lung. Unfortunately, the inflammatory response doesn't stop there. Persistent inflammation leads to destruction of smaller airways, causing air trapping in the due to inflammation. Air trapping where the air leaks into the lungs and apologies, where the air gets stuck in the lungs, leading to breathlessness and a breakdown of lung extracellular matrix, that is weakening of your lung structure, making it more vulnerable to the chronic disease. Beyond the airway destruction, TB survivors often develop the fibrosis, that is excessive scarring that stiffens the lung, and there is a pleural thickening and calcification which hardens the lung walls. Yeah, which means there is a lesser lung capacity to get air into your lungs. So together, this was a greater reduction in your lung function and increasing the likelihood of the TB survivors developing COPD. And form of COPD is emphysema, yeah, where the air sacs lose their elasticity and there is a lot of gas trapping in the lungs. So how to diagnose this? As in my latest video, I explained about the forced expiratory volume in 1 second. That is the first second of your breathing out amount of air you breathe out, and the forced vital capacity, the FVC, and that ratio should be less than 70%, indicating airflow obstruction. And this is the major criteria where we actually categorize a person having an obstructive lung disease. And in terms of patients with tuberculosis, due to the massive damage, they also have an increased residual volume to total lung capacity, and that is greater than 45%. Yeah, and showing that there is a air trapping. And also there is a reduced total lung capacity, which is less than 80%, indicating restrictive lung disease. And also there is a decreased diffusion of the carbon monoxide, that is DLCO, and that is less than 80%, which also reflects the impaired gas exchange. So in short, TB doesn't just end with treatment. The long-term inflammatory and structural damage mimics an overlap with COPD, making early detection and appropriate management very important for improving the outcomes in TB. Now, let's talk about an often overlooked consequence of tuberculosis, post TB lung disease, PTLD. While many believe that TB treatment marks the end of their respiratory issues, research tells us otherwise. Studies indicate that 30 to 50% of individuals who have recovered from TB develop a long-term lung complications. And also, 21% go on to develop COPD. So, why does this happen? TB leaves behind scarring and fibrosis in the lungs, which can result in a chronic cough, breathlessness, and sputum production. Over time, these structural changes in the lungs lead to significant respiratory impairment. So, the post TB lung disease is not a single condition. It encompasses various forms of lung disease, including obstructive lung disease, such as TB associated COPD, bronchiectasis, where the airways become abnormally widened, and cavitary disease with persistent lung cavities post TB, fibrotic lung disease, which stiffens the lungs, making breathing very difficult, pleural disease causing chest tightness and breathlessness, and pulmonary vascular disease affecting blood flow and increasing strain on the heart. So, understanding this is very crucial in the early intervention, and effective management would be then provided to the patient. The question is, how can we better diagnose and support the individuals at risk? So, let's explore that further. So I'm going to actually, as you can see in the slide, I'm going to provide you insights on the GOLD update. GOLD stands for Global Obstructive Lung Disease. And in 2023, GOLD guidelines actually introduced a concept of COPD etiotypes, where it actually indicated a difference between a COPD triggered by the cigarette smoking and a COPD triggered by infection, and the infection related includes TB infection. So TB COPD, TB COPD. So COPDI is that term which most of the healthcare professionals use. And in 2024, goal statement on the pathogenesis of COPD also highlighted that TB is at a risk for COPD, and their systematic review pooled prevalence of COPD in patient revealed 21% of people with the TB survivors developed COPD. Another common term used is TOPD, that is tuberculosis obstructive pulmonary disease. So why I'm actually telling these terms here is it is very important. If you go to the shop and get a can of juice or Coke, whatever it is, if you're really conscious of your health, you would actually investigate on the ingredients and also the sugar levels. Likewise, when you actually are the main survivor of TB or infected with TB, you need to know what are the terms your healthcare providers are using to communicate with you. At the same time, healthcare providers should use a common term which the lay public is able to understand, and so that they can actually stick around to the effective management care which the healthcare provider provides to the individuals with TB or COPD. So the main point I here want to stress is the communication matters, and so hence the common terms and understandable terms should be communicated to the people who are suffering from infection. It's the TB or COPD, whatever it may be. Now, I'm going to dwell in this slide about the overlap symptoms because both the TB and COPD have some similar symptoms that might overlap and that might lead to misdiagnosis or underdiagnosis or delayed treatment. Yeah. So studies show that 60 to 70% of TB survivors experience chronic cough, shortness of breath, and sputum production, which is also an hallmark symptom of COPD, chronic obstructive pulmonary disease. So both conditions, TB and COPD, lead to airflow limitation, fatigue, chest tightness, making differentiation very, very difficult among the healthcare professionals, especially in the primary care setting where the resources are minimal. And the challenges in diagnosis is TB survivors often continue to exhibit chronic respiratory symptoms, leading to misdiagnosis or delayed identification of COPD. And in 2024, the study by Kim et al. Found 9.6% of TB survivors are at increased risk of COPD, and and 2.8% of them experience COPD related hospital admission. And the other major challenge lies in the underdiagnosis. Many TB survivors do not seek additional care for lingering respiratory symptoms, assuming their breathlessness or chronic cough is their lasting effect from their past TB infection rather than an indication for COPD. So as a result, then the COPD remains undiagnosed and untreated in significant portion of TB survivors. That increases the risk of exacerbation and hospitalization and reduced quality of life. So the key takeaway I want you to take it from this slide for you is the post-TB respiratory symptoms should never be dismissed. Early detection through spirometry and targeted screening can ensure that the individual receive timely COPD treatment so that they can improve their long-term lung health and overall well-being. Now, let me actually bring to light some of the risk factors for COPD in post-TB patients. The first one is I would like to shed light on the previous lung damage. I've mentioned about the scarring of the lung as a result of TB, and scarring that leaves a structural damage increases the likelihood of developing the chronic airflow obstruction and then the COPD. And secondly, the smoking. It is a double threat. Smoking, a major risk factor for COPD, and that increases the lung damage structurally. Yeah, in COPD, there are two major categories: chronic bronchitis and emphysema. And emphysema is particularly talking about the loss of the structural damage to the air sacs, that is the alveoli, we call it in the scientific term. So air sacs is the end part where your air which you breathe in ends in, and from that air sac, then the oxygen needs to get into your body, and the carbon dioxide from your body has to get out of your body. Yeah, so that end point, structural damage is happening, and therefore there is air trapping, so it's no longer functional. And that's one of the main thing happens in emphysema, a category of COPD. In TB patients, smoking worsens the disease severity, and that increases the risk of recurrence and drug resistance, and also slows the sputum conversion, yeah, the mucus conversion. And what the research findings says, Alud et al. Confirm positive association between TB history and COPD, and independent of smoking or biomass fuel exposure. And another researcher groups, Brian et al., found never smokers with prior TB had a stronger association with COPD, especially in those under 40 years. And smokers with a history of TB face an 8-fold higher risk of developing COPD than the non-smokers. Now, the other factor, risk factor, the biomass exposure, it's a silent killer. Okay, and COPD is the leading cause, we all know, in developing countries due to prolonged exposure to indoor cooking smoke. Increased TB risk in studies show that 3.56 times higher odds of active TB in biomass users. I also earlier in my slide mentioned about the insights from Professor Ajit, how in UK, income country, it's also a major public health challenge. So it's no longer, I would, according to me, it's a disease of developing countries, also inside the developed countries, because we are all everywhere in the world, and there is movement of people, and also there is actually genetic kind of factors, which environmental factors all play a role, and there is a higher air pollution, which also contributes to this challenges of developing TB in the high economic countries. So, looking into the other challenges are the health resources, what is needed to research, how much of research is invested in identifying these challenges. That also speaks a lot about how we can manage this challenge. And the other thing I would like to shed light is the low socioeconomic status. TB and COPD are both linked to malnutrition, overcrowding, poor healthcare access, and indoor pollution. And the other main thing is I've in my YouTube channel, Breathe and Thrive, I populated a video earlier about the research in the UK related COPD to diabetes. In that was confirmed research findings. So COPD and diabetes are correlated, and people with COPD develop diabetes, and it's also actually 2 to 4 times higher risk in developing TB. Okay, so individuals with diabetes have that 2 to 4 times higher risk of developing TB. So systemic inflammation from diabetes contributes to COPD progression, making glycemic control very much important in the prevention. Now, looking into the vitamin D deficiency, weakened immune responses increase TB susceptibility. So in COPD, vitamin D deficiency is more linked to frequent exacerbation and inflammation. And supplementation of vitamin D is under research, and we are exploring, and there are many researches out there. So though we don't have a concrete evidence and consensus widely, but vitamin D, like we have learned the science, it plays a major role in our immune function. So it needs to be looked into, and it is one of the deficiency of vitamin D is one of the higher risk factor. And then the small airway disease. I've spoken about the pathogenesis, and by now you understand that there is a damage in the small airways. So both TB and COPD damages small airways. So that leads to chronic respiratory symptoms and also further leads to impaired lung function. And TB-associated COPD, TOPD, it's a very much higher growing concern where small airway fibrosis develop post-TB. And that leads to the symptoms of chronic cough, breathlessness, and fatigue. So it mimics the COPD symptoms, and that's related to the post-infection. And finally, the risk factor, which I would like to mention, is the accelerated aging and systemic inflammation. Chronic inflammation in TB and COPD accelerates lung aging, and that causes cellular lung damage and then other comorbidities related to that. So the key takeaway from the slide I would like you to take is both TB and COPD share multiple risk factors, and so it demands urgent need for integrated care strategies to prevent, detect, and manage COPD in TB survivors. So early intervention can significantly improve long-term lung health and also quality of life. Now, how do we diagnose COPD? Although I just briefly touched on the misdiagnosis, underdiagnosis in my earlier slide, it is one of the biggest challenge, the accurate diagnosis. So the overlap in symptoms can make it difficult to distinguish between post-TB lung damage and the COPD, leading to potential underdiagnosis and delayed treatment. And the gold standard for lung function, for obstructive lung disease, is lung function test spirometry, and measuring that FEV1 by FVC ratio. And if that ratio is less than 70%, it confirms the airflow limitation, and which is an hallmark of diagnosis of COPD. And other tests like CT scans, chest x-rays, why we need imaging, like it helps to differentiate between TB-related lung scarring from emphysema, and that actually emphysema is a characteristic of COPD, one category of COPD, as I mentioned earlier. So what are the challenges in diagnosis? Symptoms overlap, chronic cough, breathlessness, sputum production. It occurs both in the TB survivors and the COPD patients, and that leads to the misdiagnosis or the delayed identification of COPD. And also, TB survivors may assume their persistent symptoms are just a leftover effect of TB. So that actually then delays their medical attention because they don't actually attend to that. And also the underdiagnosis has been huge because of the criteria applied to the diagnosis and different terms exchanged between the healthcare professional. All are the contributing challenges. So the key takeaway here I would like you to take away is early diagnosis is very much important for effective management and better quality of life in TB survivors, whether they have a COPD or other triggered infection or post-latent TB. So by integrating the spirometry imaging and clinical assessment, we can ensure that COPD in TB, post-TB patient especially, is recognized early and managed appropriately. So, as we move on to the management strategies for post-TB COPD, I would like to stress it's important to understand the multidisciplinary approach in improving the lung function, symptom control, and also overall well-being. As you can see on the slides, I'm going to delve into the four main themes here. The evidence-based management approaches, these are all as well. So the first one is the medication. Where it is under that you can see a list of things what people will be provided, and this is, shares a similarity with the chronic obstructive pulmonary disease, any obstructive airway disease. Okay, so bronchodilators, the beta agonist or anticholinergic, whether your blue inhaler or brown inhaler, whatever you get from your GP or your consultant, what it does to you is, if you're an individual who have chronic obstructive pulmonary disease or TB survivor, it helps to relax your airway muscles and improve your airflow. And the inhaled corticosteroids, what you get is going to help you reduce lung inflammation and also prevent exacerbation. And to remember, corticosteroids also have a side effect where it increases anxiety and depression in people. So more so of other body-mind practices need to be incorporated if you are taking corticosteroids. And long-term oxygen therapy is recommended in severe cases with chronic hypoxia. And mucolytics, they are helping to thin your mucus so that it makes it easier to clear your airways. And secondly, I want to throw light on pulmonary rehabilitation. Pulmonary stands for lung, so it's your lung rehabilitation because you need to rehabilitate your lung, get back to a stage where you can live a better quality of life because there's a huge damage caused to your lung. So what is lung rehabilitation or pulmonary rehabilitation? It is a structured program combining breathing exercises and physical training and psychological support, which is key here. And studies include, I mentioned the studies from Respiratory 2013. It has shown that pulmonary rehab significantly improves lung function, exercise capacity, and the quality of life for COPD patients. But there is no studies I can find now whether there has been involvement of TB survivors and comparing it with COPD and how it affects. But the principles lies the same here. Yeah, even there is no much large evidence, pool of evidence to show the effectiveness or the efficacy of pulmonary or lung rehabilitation. It is common sense. The lung damage needs rehabilitation. Yeah, so you need to help your lung to rebuild with some breathing exercises, physical activity, and psychological support, where lung rehabilitation plays a huge role, and the referral should be made at an earlier stage when the patient TB survivors are infection free. And thirdly, the lifestyle interventions, smoking cessation, which is most effective way to slow disease progression, and nutrition support helps to maintain pulmonary function and also muscle strength essential for daily activities. Now, the key thing I would like to discuss here, the integrative medicine, because body-mind plays a huge role and we cannot treat the lungs alone, and our body need to cooperate. Our mind need to tell us, you need to go to that breathing session, or you need to go out and walk, or you need to eat that whole grain food. Your mind has to tell that to you, and that will not tell talk to you if your mind is not in a state of calmness and in a state of intuitive decision making, and not going into that boredom or quick fixes, and not actually getting into a stage where depression masks your intellectual capacity of decision making. Yeah. And people with cough, breathlessness, and fatigue are in a state of burnout, and that leads to masking depression symptoms. Okay. So they are not in a state to decide, and the caregivers play a huge role here in supporting people with a COPD, or people with COPD related to post-GB survivors. So integrative medicine actually involves the caregivers and treats the root causes, not the symptoms. And it combines the conventional medicine with holistic approaches and practice like breathwork, meditation, nutrition, and movement. So if you'd like to know more about the integrative medicine approaches, in my previous recent video, I've actually given much information on that. So you're more welcome to go back after this webinar and watch that. Now, I'd like to actually bring you a case report. I tried to get a live experience from any TB survivors, but I was not successful in getting that. So I have actually made an effort to help with a case report. And this has been published, the case report on the post-tuberculosis chronic pulmonary obstructive pulmonary disease with acute exacerbation of COPD with atrial fibrillation with aspergilloma. And it's from the Tejas et al. And it is the Indian way, or Indian approach to post-tuberculosis chronic obstructive pulmonary disease. So I would like you to lead you on that and help you to understand what this patient is going through, how is the management strategies being tailored in an Indian way, and what the research gaps are. Yeah, let me take you there. So I'm going to introduce this lovely man here, 69-year-old male, and he had presented himself to one of the hospitals there, and in the HDU of that hospital on the 5th September 2023. So on presentation, his symptoms are dribbling during maturation, that is urination 4 days, an increased force of maturation, and chest pain 1 month, and cough 5 days, fever 10 days, irregular heart rhythm, hypertension, and constipation. So he has a hell of a lot of symptoms, and he's still there alive and sitting in front of the doctor and talking to the doctor for looking for some fixes. And so going in depth of the patient history and information on the patient, you can displayed, you can see is her weight, height, and BMI. And his medical history says that it had hypertension, and he had a benign prostate hyperplasia, and he also had underwent some surgical procedure. It is TURB is a surgical procedure for the prostate removal. So he had underwent that 12 years ago, and his condition is post-TB COPD with acute exacerbation, atrial fibrillation, and which is in control, and aspergilloma. So on physical examination, his respiratory systems show that there is a reduced air entry bilaterally and bilateral crepitus, as the lung sounds, and crepitus and wheezing. And cardiovascular system, it revealed like tachycardia because with an irregular rhythm. So that is actually one of the findings. I would not explain now why. And these are the presentations. And abdominal examination revealed abnormal bowel movement, and facial exam revealed dull expression and consistent with hypertension. And his investigation revealed he had went through a range of investigations there, as you can see on the slide. He went through his chest x-ray. It showed some patchy fibrosis bilaterally and emphysematous lung fields. And ECG shows atrial fibrillation, and the abdomen and pelvis scan showed no obvious abnormalities. And the upper GI endoscopy that revealed an atrial ulcer and diffuse pangastritis. And also the HRCT thorax, there is a cavity lesion in the right lung. And 2D echo showed some mild degenerative valves, mild PH and no clot or vegetation, and mild pericardial and perfusion, and left ventricle 50% effusion rate, and grade 1 diastolic dysfunction. So you can see it gives a picture for you if you're a healthcare professional. And this might be someone with a individual with a TB survivor went through these investigations. You can relate to this. And consultation and opinions given after all the investigation, range of investigation. Pulmonologists advise bronchoscopy further, sputum AFP and CBNAT, and ENT had actually found that hearing loss, so he prescribed Neurobion Forte and hearing aid trial, and gastrologist prescribed some HP kit and audiometry, severe mixed hearing loss in both ears. So these are the opinions. I want you to drag you all the way down to management and care plan. After all of this investigation, is care management plan included chest physiotherapy, regular chest physiotherapy, and general condition as moderate under observation with special care. Now, let's come to the discussion. So, what are the complications? So, obstructive ventilatory defect found in 55.3% of treated TB patients with diagnosis, and TB increases risk of COPD, especially in the elderly. So, it's diagnosis post TB COPD with acute exacerbation, atrial fibrillation, and aspergilloma, and it's previously diagnosed as tuberculosis 10 to 12 years ago. And you can see where he was treated, and history of benign prostate hyperplasia, and went through a surgical procedure for that. And higher prevalence of treated pulmonary tuberculosis patient. You can see the FEV1 typically lower than the FVC in TB patient, and reduced FVC after 15 years of follow-up. And his exacerbation actually highlighted as he had been an annual hospitalization and increased COPD exacerbation, leading to more worse prognosis and increased mortality rate. So the lifestyle changes it should be incorporated rather than alone prescribing a chest physiotherapy is smoking cessation, dietary support for energy requirement, and pulmonary rehabilitation. And medical treatments, medications to reduce lung inflammation and improve airflow, antibiotics for infection, and oxygen therapy if required, and surgical option, lung transplant or volume reduction surgery for severe cases. So, but more research required for pathophysiology of post-TB COPD, and to also early detection of biomarkers to detect a severe post-tuberculosis lung disease. And also, people should be incorporated with the management plan should be incorporated with the pulmonary, there's a lung rehabilitation and better treatment strategies to reduce premature mortality in the post-tuberculosis lung disease patient. So what are the key takeaways from this case study is the person had showed some overlapping symptoms. So there's a delayed diagnosis, and there's a significant challenge in TB survivors. Many individuals continue to experience overlapping symptoms like chronic cough, shortness of breath, and sputum production. And as a result, they may not seek further treatment because they assume these symptoms are just lingering effects of their previous TB infection. And this often leads to underdiagnosis of COPD, which then leads to serious consequences on the long term and affects their lung health. And also for the early spirometry screening is absolutely critical for identifying COPD in TB survivors. So spirometry is very, very simple and effective tool to detect the airflow limitation. And in most part of the primary care settings are provided with the spirometry in UK nationwide. And so it is about a matter of testing that and clarifying it whether the TB survivors are having COPD development in the primary care setting. And also The risk factors for TB, as I earlier mentioned, smoking, one of the major risk factors, and that significantly increases the COPD development. And additional to the fibrosis and scarring, the leftover from the previous TB. So these are all the key takeaways we need to focus on. And in teletherapies, we offer support for individuals with post-TB COPD through a comprehensive care plan. So do contact us if you're watching this video in the webinar. So I would like to express my thank you for your attention, and you can drop your questions at the end of the session. I would respond. I mentioned I already got one question, which I'll be answering very shortly, and I want to tell you about a 30 minutes free consult, which is available for people. And at Teletherapy, we provide that offer that free consult on the basis of humanity to understand your problems, so that to also understand whether we are the right person to offer some changes, meaningful changes in your life. Yeah, so do use that 30 minutes free consult meaningfully and book a consultation with us. And don't miss out to tune into our next webinar this Friday. I'll be talking about the Ayurveda for respiratory health at 10 a.m. and through the same channels where you're present today. And do share that with your friends and family, or the people you care for in your life. And with that in mind, I would like to also display some of the contact details. I'm just going to hold that here. And while you're actually recording our contact details, as I promised earlier, first I'm going to reveal the answers for your the questions what I actually put on earlier. So for the question, which of the following is the most common symptom of both TB and COPD? The answer is B, this chronic cough. Chronic cough is the hallmark symptoms for both the TB and COPD. So in TB, it's often persistent and productive mucus, and while in COPD, it's a key symptom due to the airflow limitation and mucus production again. So they both share the similarity, so it's very difficult to diagnose whether you're developing COPD after your TB, but do actually consult your healthcare professional so that you can have a better idea. And for the second question, the true or false question, whether tuberculosis can only affect the lungs, it's false. While the person who answered in the chat, Muhammad, is right, it's false. And so while TB primarily affects the lung, it can also affect other parts of the body, like kidney, your bones, your lymph nodes, your brain. So it is not only localized to your lungs. And the final question, which I put on, what percentage of TB survivors are in the respiratory conditions which develop COPD, chronic respiratory conditions? So that's the answer is 21%. Because Gold 2020 systematic review revealed that 21% of people are developing COPD. And although previously there was actually a research showing that 30 to 50% of individuals exhibit COPD symptoms and other things, not only COPD, chronic respiratory range of chronic respiratory symptoms. 21% is by the Gold 2024 has a pooled evidence from the systematic review from the global studies. So that's the answers. And one of the questions which I received while I was doing my presentation is on whether CPAP helps in the COPD people. I'm just going to go on to the question. So what role, Mohammed had asked, what role CPAP machines play in COPD patient? Is it safe for them to use? I would say that if COPD patients having a coexisting overlapping OSA, obstructive syndrome, then they can be used obstructive sleep apnea, then they can actually be advised with the CPAP to maintain the airway patency, reducing the nocturnal hypoxemia and improving the sleep quality. It may also lower exacerbation. But more so, BiPAP is preferred over for the CPAP for severe COPD with the CO2 retention, because it is actually going to have more effect on the mild hypocapnic respiratory failure in some cases. So BiPAP is preferred over CPAP. So hope that answers your question, Mohammed. I understand that you left the chat, and this is also recorded while it's actually live, so you can watch back your answer. And thank you for your question, and thank you for joining this webinar this morning today. Now, finally, I would like to say thank you to all of you who have joined this webinar. And healing is not just about treating a disease, but about empowering individuals to breathe easier, live fuller, and embrace the future with hope. And together, I strongly believe we can make a difference. And so have a good day. And don't forget to tune in tune in this Friday at 10 a.m. On the 28th of March for Ayurveda for respiratory health. Thank you. I see you there.